I want to welcome everybody to session number 145. It's about the development of a decision aid for decisions about radioactive iodine therapy among patients diagnosed with thyroid cancer. I'm Becky Johnson, and I will be your facilitator this afternoon. Really happy to have you here. And I would like to introduce our special speaker for this afternoon, Alaina Carr, PhD, and I'll give you a little bit of information about her. She's a clinical psychologist at Georgetown University in Washington, D.C. Dr. Carr received her bachelor's degree in psychology from the University of Colorado, Boulder, and her doctoral in clinical health psychology from the University of Colorado in Denver. She also completed the Meaning-Centered Psychotherapy Program for Cancer Care Providers at Memorial Sloan Kettering. Dr. Carr has specialized in experience working with cancer patients and their family members or caregivers across the cancer care continuum regarding diagnosis, treatment, survivorship, and end of life. She works with clients to help them better cope with health-related stress. And any of us that have been told we had cancer understand that stress factor. So without further ado, I would like to introduce you to Dr. Carr.
Hi, everybody. I just want to thank everyone for having me come talk with ThyCa. The organization does such important work, and us at Georgetown University and MedStar Health are really fortunate to be able to share some of our findings with some of the research studies that we've done. So at any point in time you have any questions, feel free to send them in the chat. I'll do my best to stop the presentation at any time and make sure to answer the questions. If at any time there's a burning question, Becky, if you would, you are more than welcome to interrupt or say there's a question in the chat, and I can make sure to answer it during the presentation.
Will do.
Okay, great. So I don't have any disclosures to identify any conflicts of interest before we get started. I do have a disclaimer. So this talk today is going to be focusing on decisions about radioactive iodine therapy. So the information provided in this talk is intended for educational purposes. Even though I see patients in a clinical setting and I do research at Georgetown, I'm not providing any medical advice per se. This information is not intended as medical advice or directions. And if any individuals who are attending the talk are viewing this information, we very much so strongly advise that you consult with any of your healthcare team members about medical decisions or concerns. And like I said, even though we are talking about decisions about radioactive iodine therapy, this talk isn't intended to persuade you to have radioactive iodine therapy or not have it. Really, what we're trying to do is promote an informed choice about radioactive iodine therapy and provide more of a balanced presentation of what we found with some focus group participants in some of the studies that we've done, and share their experiences with their journey in making these decisions. So a little bit of background information. I'm sure there's a mix of people in the talk today who are either healthcare providers, researchers, or thyroid cancer patients, or maybe even family members. So everyone might be coming into this talk with different levels of knowledge or experience with thyroid cancer. So this talk will be focusing on intermediate risk differentiated thyroid cancer, which I'll refer to as DTC as I move forward with the talk. So in the US in 2021, there were about 300,000 cancer survivors with intermediate risk DTC. And although we know that there are excellent survival rates for patients with DTC. A lot of them are partly due to radioactive iodine therapy. And if we look at the survival rates for individuals with intermediate risk DTC, the 15-year survival rate is approximately 85 to 93%. However, the relative benefits of RAI may only apply to a subset of intermediate risk patients. So when I say a subset, there is some data out there that's showing that individuals that are 45 years or older and those with larger tumor sizes might experience more relative benefits of RAI. We also know that in 2015, the American Thyroid Association issued their clinical practice guidelines on recommendations for individuals with differentiated thyroid cancer and considerations for RAI treatment. And they had indicated that it's recommended that those that fall in this intermediate risk range should consider RAI treatment. So that means they're not saying it's absolutely necessary or it's not beneficial. It's this gray area. So with this gray area in mind, there are different considerations that someone going through this treatment decision-making process might think about. Those might include patient comorbidities. So that means you have another type of health condition that might impact how the treatment is targeting the tumor. Is there preferred disease surveillance procedures? Does that work with your institution or the institutional resources? And then also patient preference. So if there is this gray area between the effects of RAI on reducing the tumor size and having a curative intent, how do you weigh the risks and benefits of that? And we also know from SEER data that 76% of patients across all risk levels, so this is both high, intermediate, and low, do receive RAI. However, more than half of those patients reported that they felt they didn't have a choice about having RAI therapy. So some other things that we know about RAI is that there are differences in side effects that people may or may not experience. So different data that's been published on patients who have received radioactive iodine therapy have shown that some patients experience moderate to severe symptoms, so between 5 to 86%. That's a pretty big range if you think about it. And these can affect their salivary glands, their face, so your eyes, nose, and also your mouth. And we also know that there are differences in short-term and later effects of radioactive iodine therapy. So there might be some magnification of different types of malignancies. There might be some secondary malignancies for more solid tumors. So those might include increased risk for breast cancer, increased risk for uterine or lung cancer, and then salivary gland cancer. And then there's also a reproductive impact. So it also, in having radioactive iodine therapy, some of the recommendations are to delay any type of family planning because of the radioactive iodine that's in your system and waiting for it to completely leave the system before you start trying to conceive. And then other individuals have also reported gastrointestinal problems as well. So you can see for an individual that might fall into this intermediate risk range, there's a lot of different factors to consider in making a treatment decision for whether or not they should go forward with radioactive iodine therapy or not. So I'd also like to highlight some of our prior work that led to the current study that I'll be presenting on. So some of the work is published in this paper where you can see the image here looking under the hood of Cadillac cancers. And some of it has yet to be published, although we're presenting it here. So we had done some pilot survey work with 106 participants, and 84 of those participants had radioactive iodine therapy, and 22 did not have any radioactive iodine therapy. And among all of the survey participants, based off of their responses, 50.9% of participants reported not having enough information at the time of making an RAI treatment decision. So about half of people in the sample were feeling that there's just not enough information out there to really make a decision. And more than 30% of patients in our sample with differentiated thyroid cancer were frustrated over the lack of information about symptoms following radioactive iodine therapy. And in our sample, 20% of patients would have made a different decision about radioactive iodine therapy. So, having some decisional regret was starting to show in the data from our survey participants. We also found that participants in our study reported significantly worse overall symptom burden among those who had received radioactive iodine therapy versus those without. And we also found that symptom burden was related to lower quality of life. So thinking about overall functional well-being in both physical, psychological, cognitive, mental domains in your life. So if we think about the pilot survey data from our prior work, it strongly suggests that there needs to be some support for patients as they go about making different decisions about whether or not to have this type of therapy. So some type of decisional aid might be beneficial. And when I say a decision aid, what I mean by that, you can see the definition in this slide here, is they're really tools designed to help patients and providers talk about healthcare treatment options. And by doing that, you're able to help patients understand their choices, the risks and benefits of the healthcare treatment options. And by doing that, you also help make an informed decision. And other literature out there on decision aids show that within cancer populations in general, they can really improve decisional outcomes, which means that can help increase knowledge, decrease any decisional conflict, and also increase patient satisfaction with treatment decisions. So that leads us to our current study where we really wanted to know whether developing a web-based decision aid about radioactive iodine therapy decisions would be useful for patients that have either received radioactive iodine therapy or have yet to receive it, or still going through that decision-making process. We also wanted to know what specific factors patients might find most important when making these decisions about whether or not to have radioactive iodine therapy. So where the study was conducted at MedStar Georgetown University Hospital, and we were able to have providers at the hospital refer patients that had received a diagnosis of differentiated thyroid cancer within the last 3 years. All of our patients were 18 years or older, and they also had access to a computer, phone that had internet connectivity, since we were asking them to complete a brief online survey and then participate in a focus group. And the online survey just had a brief questionnaire asking about basic medical information, such as if you were diagnosed with differentiated thyroid cancer, when were you diagnosed? Have you received radioactive iodine therapy? And also, do you have health insurance, and basic background information? So then what we did was, after we had patients complete the online survey, we invited them to participate in a focus group. So a focus group is a virtual meeting where questions are asked to a group of people with firsthand experience about a specific topic. So in this situation, we really wanted to understand patients with thyroid cancer's experience in making these decisions about whether or not to have radioactive iodine therapy, any types of challenges that they might have experienced, and also what would be useful content to have on a potential web-based decision aid to really help other individuals who have yet to go through this process really weigh the pros and cons for what works best for them at their particular circumstances in life. So we ended up having 4 focus groups. All of them were conducted over Zoom with between 3 to 8 participants per group. And a moderator asked open-ended questions about the patient's experiences with differentiated thyroid cancer, their experiences moving forward or not moving forward with radioactive iodine therapy, and then useful content to include on the website. And based off of the survey responses, our participants, we had 25 people enroll in our study and complete the survey. And you can see here that in terms of who our patients were, we had primarily people who identified as white, and then Asian, as well as Black or African American, and we had a few individuals identify as more than one race. And the average age of participants in our focus group study was 39 years old. And in terms of ethnicity, our sample primarily was composed of non-Hispanic or Latino, Latina individuals. And the majority of our sample was also women. And then in terms of diagnosis type and stage, the majority of our sample were individuals diagnosed with papillary thyroid cancer, which is the most common histology for differentiated thyroid cancer. And then the most common stage was stage 1. We also had quite a few individuals not really know what stage they were. So based off of the information provided by our focus group participants, there were several overarching themes that were showing up in their experience with receiving the diagnosis of differentiated thyroid cancer and then moving forward or not moving forward with radioactive iodine therapy. And you can see that one of the biggest pieces was unmet informational needs about long-term side effects of radioactive iodine therapy. So this image on the right-hand side here on the screen shows inflammation of salivary glands. Many people were reporting that even 6 months or over a year after having radioactive iodine therapy, they were still experiencing some long-term symptoms, and they weren't aware of having those symptoms or that was a possibility of this type of treatment. They also indicated that they really weren't sure about the size of the dose response relationship for radioactive iodine therapy and how much that might relate to or influence the severity or type of side effects, and whether the size of the RAI treatment dose impacts the need for subsequent treatments. So there were multiple participants in our sample that suggested having a range or a scale or some information out there providing an overview of correlating dosage size and side effects or general information about scans would be helpful. A participant in the chat just asked, did you include the effects of thyrogen shots prior to RAI therapy? So I'm wondering if that question is in response to our pilot data that I presented on a few slides before, or if that's related to the focus group interviews that we asked. Wondering if Mark Valentine could explain a little bit more about the question. If it's related to the focus group participants, we didn't ask about the effects of the thyrogen shot prior to RAI therapy. Just a question related to the side effect of thyrogen in addition to RAI. I'm not quite sure, but it's information I can look into after the presentation and get back to you. So I also wanted to include some of the quotes from some of the focus group participants in our sample. So if we think about the long-term side effects of RAI, we had one person share their experience saying 6 months after at work one day, I had a clogged gland and the side of my face swells up. They don't talk about those long-term things in the grand scheme of things. I'm alive. I held my breath. I didn't lose all my hair, but those little things, when they pop up, you're just like, I didn't know this was going to happen. I think that the long-term care as you're going through it should be explained a bit more. So this gets back to that idea of, not fully being aware or not fully understanding the impact or the long-term effects of different types of symptoms that can persist even 6 months or longer after this type of treatment. The other thing that showed up in terms of unmet informational needs from focus group participants was the low iodine diet. So there were many patients who indicated that they didn't quite know where to go for information for recipes or just generally what foods you should avoid when you're on the low iodine diet. I'm aware that ThyCa has wonderful resources and a cookbook on their website for anyone who's interested in more information on the low iodine diet. However, keeping in mind, people in our sample didn't always utilize the ThyCa resources. However, we're hopeful that with this talk, more people can become more aware of the different resources that ThyCa offers. So here you can see the different types of unmet informational needs that are showing up for individuals who weren't fully aware of what's required from the low iodine diet. So someone had said, I also found that some of the information online was kind of contradictory. For example, egg whites. On some websites, they're saying, oh yeah, it's low iodine, you can have it, no problem. Some other websites that I went on that were not affiliated with, and that's related to wherever that individual had their treatment, for example, they would say even egg whites have iodine, so you should not incorporate that into your diet. I wasn't sure why there was such conflicting information because I was expecting to see some sort of streamline. That is, you can have, and that is what you shouldn't have. So really getting at this idea of with all of the information that's out there, where can you go to find trustworthy, credible information that's not contradictory? Where do you go to trust this information? And Becky Johnson had just mentioned that the cookbook on the low iodine diet can be sent to individuals for free. So that is very helpful to know. Thank you, Becky. The other piece was family and fertility planning. So depending on where an individual is in their life, there was some uncertainty or not knowing whether or not fertility preservation should occur prior to going through with radioactive iodine therapy, or how long someone should wait. So what's the level of urgency? Can I delay treatment a little bit? Because right now at this time in my life, fertility planning and family planning is really important. Or maybe that's not something I've considered, but it might be something that's important to me a few years down the line. How do I best prepare for this? So we had somebody say, I'm in the middle of fertility therapy, so I was waiting. I asked my endocrinologist many questions. What should I do? It's kind of like a dilemma. Should I go without RAI? Or what's going to happen to my fertility? I'm in a time constraint. Am I supposed to have my egg retrieval? Should I start with it? Which one should I do first? Surgery, retrieval, and then RAI? So just a lot of not knowing which is the most recommended avenue to go. Where do I go for this information? Who should I talk to about this? The other major unmet informational need was the radioactivity period post-radioactive iodine therapy. So not feeling as though there were clear instructions conveyed about how long somebody needs to isolate to make sure that they don't expose anyone else to radioactivity. What sort of preventative measures are needed in terms of making sure you're washing your bed sheets, or how long before you can see loved ones. So that was really emerging from our focus group participants in terms of, just not knowing what the requirements were. So we had somebody say, they tell you if you have kids that you should have, I forgot the actual timeline now, but I think it was like 2 to 3 weeks. You shouldn't be around kids. But at the time I had a newborn niece. And so I was so scared. So I was like, I'm going to double that time. So in the end, I didn't see her for 2 months. Those emotional things are hard. It was just a choice that I made. But I think you're just so unknown that you don't want to hurt anybody else. So really feeling like by moving forward with this type of treatment, or just not knowing the safety precautions involved, really missing out on some other aspects of that person's life that's really important, like getting to know a niece and wanting to make sure that niece is safe. And then the last thing that was showing up in terms of unmet informational needs was information for family and friends. So there were several participants who were saying that receiving a diagnosis of differentiated thyroid cancer can be really overwhelming, understandably so. And it can be a lot trying to not only navigate your own reactions to it, but having to provide education or more information to family and friends when you might not have the energy to do that. You might not have the emotional or mental energy to do that, on top of everything else you're having to decide in this treatment decision-making process. So feeling like it was just really hard to find information to tell family and friends, this is what radioactive iodine therapy is. This is what it's going to look like. Here are the benefits for it. Here are some of the outcomes that we know about this type of treatment. So something else that started showing up in our focus groups was the impact of personal values on how somebody looks at the pros and cons of this type of therapy. So really their values are affecting, the individual values are affecting the treatment making process. And that can really contribute to individual preferences in weighing the pros and cons. So among focus group participants who had received radioactive iodine therapy, for some people, the prognostic benefits of treatment were considered to be one of the most important factors in their treatment decisions. They had indicated that prevention of additional surgeries was a big plus. And they had also indicated that increasing your quantity of life was another major factor that made it more of a plus for them. However, you can also see that if this is based off of personal values, something that's considered a plus for one person might be considered negative for another, or might not be viewed in the same way. So this animation sort of shows how it's really on an individual basis what goes into your personal values for whether or not this type of therapy is in line with treatment considerations and feeling like you're satisfied with treatment. So for somebody, risk of secondary cancers or long-term or just unknown side effects of radioactive iodine therapy, or even delay in family planning, might be more negatives. Or maybe for somebody that's not as important to them where they're at in their stage in life, so that scale changes. So it's really showing for individuals, it is guided by personal values. So sort of really highlighting how individual this is. We had somebody say that I asked my doctor a lot of questions because when he said there is a risk of developing salivary gland cancers sometime down the road, even though it's a very small risk, that really scared me because I was looking at the prognosis, like the chances of survival from that versus thyroid cancer. Salivary gland cancer is much more. I had a few weeks where I was not sure if I should go through with this treatment, but eventually ended up taking my doctor's advice. So again, if you think back to that scale I just showed, how it changes in terms of what's most important in terms of pro and con, and how that can really guide what works best for you, how that informs your choice. And then the last thing that we started to see with our focus group participants was if we were to create a website that had a decision aid on it and can really help inform patients about the pros and cons of radioactive iodine therapy, what topics are most needed, what would be most helpful for people who are in that intermediate risk range that are in the midst of this treatment decision-making process. And some patients had indicated that a general overview about what differentiated thyroid cancer is and risk levels would be most helpful. And they specifically said having visual images on this website of the anatomical structures of the thyroid gland would be helpful, and the specific areas targeted in that gland by RAI treatment would be really helpful to understand. We had several participants say that there was some confusion about understanding the effects of treatment or where it was targeting, because there's such a rapid time frame from receiving thyroidectomy to needing to make that decision to consider radioactive iodine treatment, that sometimes not all of the information provided is fully digested. And then, as I had said, some patients had suggested really including information on understanding what your risk level is to better inform their understanding of the risks and benefits of this type of treatment. While others had recommended including more of a timeline for RAI treatment outcomes, such as how long before the treatment team knows RAI targets the intended areas of concern, and how long patients need to be monitored on average before they're cancer-free. As we had talked about before, really having comprehensive information on common side effects of RAI therapy, as well as estimates on the level of effectiveness on RAI based on type and stage of cancer. So really trying to understand more of that individual risk level and how effective this type of treatment option might be for the individual person. The other thing they had highlighted was ways to consider the pros and cons of RAI and how these pros and cons can relate to a patient's own values and what's important to them. So we had talked about fertility and family planning. So for somebody where right now at that stage in their life, that's very important value, considering that value in the context of this type of treatment and how that might impact you down the road. Is it okay for you? Is it a preference for you to delay that treatment so you can move forward with family planning? Or are you also okay with deciding to move forward with family planning and delay the treatment? So really thinking about not having any type of decisional conflict down the road based off of what your values are. And then the other piece that we had also talked about was the requirements for the isolation period during radioactive activity immediately after therapy. So there are many patients who said they wanted more detailed information about this period. So many people had indicated having more comprehensive logistical information could help intermediate risk patients with differentiated thyroid cancer considered the feasibility of certain circumstances needed for that isolation period adherence. So some of those logistical pieces included isolating at home alone without family or pets around, regularly washing bed sheets, consistently cleaning the shower or bathtub after use, designating a bathroom for the patient who's just undergone this type of therapy, and then also abstaining from any type of travel and being able to avoid any type of in-person interactions with women, pregnant women. So they also had indicated having specific time points on potential website decision aids, such as how long the radioactive activity period lasts before a patient can return to quote unquote normalcy to better inform their treatment decisions. So it really depends on each individual's circumstances. Do you have the current logistical means? What does your home environment look like? That really weigh into that decision to move forward or not move forward with the treatment. And then also supportive resources such as online thyroid cancer support groups. So there were many people that had indicated just the importance of having other people out there who have that shared experience and really being able to talk to someone who's lived that experience and learning from that. Again, I know ThyCa has some great online virtual support groups that many participants in our sample had indicated they really enjoyed going to. A vast array of support groups offered through different online platforms like Facebook or ThyCa, different associations, and really learning from others who might have helpful recommendations for managing radioactive iodine therapy. And then the last piece was an overview of the anticipated financial cost of radioactive therapy and follow-up appointments. So this was somewhat mixed feedback among our focus group participants in terms of the helpfulness of including this information on the decision aid website to make an informed decision. So there were several participants who said, described healthcare procedures and costs as generally expensive, but that the cost didn't heavily factor into their informed decision. And at the same time, there were other participants who indicated that knowing the anticipated cost up front and any helpful financial resources to navigate the cost was an additional important factor in the treatment making process. So some helpful takeaways from this talk today is that there's just so much complexity that goes into medical treatment decisions, particularly for patients diagnosed with intermediate risk differentiated thyroid cancer. And again, some of those complexities are the limited clinical guidelines about whether or not RAI therapy is highly recommended versus not, and also unclear information that's just generally out there about the relative risks and benefits of radioactive iodine therapy. The other piece is that, especially for patients with intermediate risk differentiated thyroid cancer, it's the decision to move forward or not move forward with it is very preference based, based off of the clinical guidelines. And the use of a web-based decision aid may help with that shared decision-making process between patients and providers to really make informed quality decisions based off of patients' values and preferences. And that the information provided from our focus group participants really highlights important areas for our team to consider when we develop a web-based decision aid. I also want to note important considerations with our sample of participants and where the research was conducted and different factors. So of the 25 people that enrolled in our study, the majority of them had received radioactive iodine therapy, and 1/5 had not received it yet. So we really captured the experiences of people who had already gone through it, and we're only able to capture a small subset of people's experiences as they were still making that decision. So just important considerations to keep in mind. And then our sample consisted of people that were receiving care at a large academic hospital in an urban area. So the experiences in the focus group that we had conducted are reflected of treatment in those types of area. So individuals who are in this process that might be attending this meeting right now, who might not be in an urban area or receive care that's not at a large academic hospital, might have different experiences as they're navigating this process. So those are some things to keep in consideration. And then everyone in our sample had endorsed health insurance coverage. So that might be a piece that factors into those who had mixed responses about whether or not having financial information would be helpful on the decision aid. So that's something to keep in mind, because maybe for people that have different types of health insurance or are in the process of getting insured, might have more usefulness or helpfulness for that specific feature. And I just saw that Becky had mentioned in the chat, can you define differentiated thyroid cancer for those new to the term? So differentiated thyroid cancer is can be thought of as a medical umbrella term for papillary or follicular thyroid cancer. And then last but not least, our results don't generalize to the experiences of individuals from multiracial and ethnic patients undergoing radioactive iodine therapy decisions. So in future studies we really want to capture the experiences of other individuals to really look at different types of health disparities that might impact an individual's experiences with moving forward or not moving forward with radioactive iodine therapy. And in line with that, I would like to highlight that we had recently received funding to move this study a step forward, where our next steps are to convene a group of medical providers and decision aid research experts for additional content and formatting of this web-based decision aid. And what we plan to do after we've convened that group of medical providers and decision aid research experts is to then take the valuable feedback we've received from both them and our focus group participants and develop a prototype, if you will, or like a drafted version of what this web-based decision aid would look like, and start to pilot test the website decision aid among additional participants to see if they find that it is useful, it is helpful, and what the impact of this type of web-based decision aid might have on informing or improving informed choice, reducing decisional conflict, and really increasing patient satisfaction with their treatment decision-making process. I really want to thank ThyCa, especially Gary Bloom, for his support in allowing us to come and talk today. The researchers at Georgetown, especially in the Cancer Prevention and Control program, we are so appreciative of ThyCa's support with us and our research initiatives. Really, we wouldn't be able to do the work that we do without having individuals such as yourself attending these talks, and also providing important feedback for ways that we can improve your experiences in receiving different types of treatments in the healthcare centers. So without individuals such as yourself or the thyroid cancer community, we wouldn't be able to do what we do and find ways that we can improve the general experience and the way healthcare providers as well as patients can work together to improve outcomes. I also would like to thank Doctors Christy Graves and Jacqueline Jonklis, who are both the principal investigators as well as my research mentors, for all of their work on this study, and also really championing these decision aid efforts that we have. I would also like to thank our research assistants, Kate and Gotham, for a lot of their hard work in the study as well. And then we have several other studies that we are always interested in having participants be involved in. So if there is ever a point in time where you are interested in participating in one of our research studies, our study contact information is here. Like I had said, we recently received funding to develop this web-based decision aid. We also have another study that's ongoing, really thinking about how we can improve symptom management related to radioactive iodine therapy. There were a couple of questions in the chat that I would like to get to that I haven't addressed yet. Intermediate risk. So I have some additional slides. Here are the different risk categories, and this is developed in line with the 2015 ATA clinical guidelines. So you can see here that the aggressive histology, you can also see the minor extrathyroidal extension and vascular invasion fall into that intermediate risk range. And then also having greater than 5 involved lymph nodes really fall into that range. The other thing I would like to point out is on the ThyCa resource page, they do have the 2015 ATA clinical guidelines, that publication available there to be downloaded. So if there are any questions about what DTC is, what radioactive iodine therapy is, and then also what these different risk levels are, a lot of that information was provided there and directly pulled from there to inform this talk. We also have another person who asked, did you notice any differences in isolation period advice between patients? I have found that the isolation period adherences can vary between hospital and then in parentheses, nuclear medicine teams, and even between rounds of therapy. I had 3 rounds over 8 months, and by round 3, the isolation guidance had changed from round 1 and 2. And in the States, is there one standard only for isolation periods? UK here. Would you agree that the success of decision aid lies in standardized information? That's a great question, a lot to unpack there. So the first question is, did you notice any differences in isolation period advice between patients? I would say yes, we did notice differences in advice. Again, a lot of that, like you had indicated, can depend on which institution was providing the treatment. So in our sample, we didn't quite collect data on where everyone had received RAI treatment. It wasn't always at the MedStar location. They might currently be MedStar patients at that time, or Inova or other different types of hospitals around the area or domestically. I think that especially for individuals in our sample, an added layer of the information and standardizing it was that many of them had either undergone the RAI treatment during the COVID pandemic. So there were a subset of people who, in addition to needing to isolate for radioactive iodine therapy, there were many family members or others that they were cohabitating with that also were isolating because of COVID. So it added this extra layer and challenge. And it says we have 5 minutes remaining. I think that, like you said, would you agree that the success of a decision aid lies in standardized information? I definitely agree that standardizing information is vital to the success of a decision aid. It's also really important as well to make sure that patients feel as though they are receiving credible and trustworthy sources of information. So really making sure that information that we're able to provide at different hospital centers, as well as on decision aid websites, are vetting the sources. Fortunately, we have a group of very talented researchers, decision aid experts, and medical professionals that are able to come in with this vast body of knowledge to really incorporate credible information within the medical decision-making realm in the context of thyroid cancer, as well as this type of treatment. I can't quite speak to differences between care provided in the other countries compared to here, although that will be certainly important to keep in mind moving forward.
I just want to really thank you for doing such an amazing presentation. I always learn new things, and we're all very grateful for the research that you've done.
Thank you so much. As I said, it really takes a team. So a lot of what we're able to present today is, the hard work of a lot of collaborators, researchers, medical professionals, but most importantly, patients and individuals such as the ones attending this talk today. Really hearing from patient voices is how we can improve the care and how we interact with different types of health institutions, and how individuals are really able to improve their health outcomes in the care that they receive. So thank you all for being such a wonderful community to work with.
We all need to give her a virtual applause. Great job.
Thank you.